This patient has 2 diopters of with the rule astigmatism, and we're going to use a toric lens. I'm photographing the iris to identify landmarks, which I'll use to orient the toric lens. I'll move the eye into the primary position. You can see it's a suboptimal pupil. And then I'll use Thermodot to mark the target axis. This is Omidria. It's phenylephrine and ketorolac. The nurse is going to inject it directly into the BSS bottle, and she'll place it into the phaco machine. I'll confirm the axis. The 3-plane incision starts with a diamond groove and then an uphill tunnel. And then I'll lift the heel of a guarded blade to enter with an internal flare, so it's 2.2 on the outside, 2.4 on the inside. Now I'll enlarge this suboptimal pupil with Healon V for viscomydriasis, and notice that there's pseudoexfoliation. The other pupil dilated wonderfully, but this pupil didn't, and that's because of the pseudoexfoliation. These are very challenging cases. The viscomydriasis helps, but if I'm going to implant a toric lens, I need good visualization. I need to maximize the pupil widening and to maintain the pupillary dilatation throughout the procedure. And that's where I'm going to depend on Omidria. I'll use a little more viscomydriasis here. I'll make the second stab incision with a diamond, and then the phaco is begun with a bevel down ozzel tip, which traps the OVD, leaves it in the chamber, which is very important. Then I'll go bevel up after I'm about halfway through the nucleus, and I lower my vacuum so I don't pull the OVD in. And that gives me my maximum effect of the viscomydriasis. I can separate the nucleus into 2 hemispheres at this point and rotate the nucleus. Then I can embed the phaco tip and chop the hemisphere into quadrants. Then I can tip each quadrant up and remove, with the assistance of this double-fingered chopper, the quadrants, always working in the deepest part of the chamber, and always working next to another quadrant, which holds the posterior capsule back. I'm depending on the Omidria to maintain maximum pupillary diameter. And this happens because the phenylephrine is stimulating the sympathomimetic system, the iris dilator. The ketorolac is an NSAID, which is blocking the prostaglandin effect that can constrict the pupil during the surgery. It is well recognized that the small pupil is associated with more complications, especially in cases like this where you've got pseudoexfoliation to start with. And then I will remove the subincisional cortex first, which is always the most difficult, because the rest of the cortex is holding the bag open like a shoe tree. This is a rather tenacious, unsociable cortex. Notice the pupil has not constricted. This is wonderfully effective. And I'm using the combination here of Omidria and the Healon V, which prevents any constriction and really maximizes my pupil widening to begin with. Well, there's a little bit that I didn't see here, but we got it out, it looks like, and now I can use the soft tip to thoroughly vacuum the posterior capsule. Beneath the OVD, you can see the bubbles aren't moving. And I'll put more OVD in. That widens the pupil a little more and tenses the globe so I can use autosert to inject the lens into the capsular bag. As the lens slowly opens up, I'll place the toric lens into the bag and hydrate the incision so it's watertight before I remove the OVD from behind the lens. I'll keep it in front of the lens so I can rotate the lens to the proper meridian, which is marked by my thermodots. I also use Virion to confirm that the alignment is perfect. So I'm using a lot of different methods. And finally, I'll remove the OVD. And this pupil has really been well managed throughout because of the Omidria and the Healon V. I can just barely see the dots. The lens is perfectly aligned, well centered, and the incision is watertight.